As we go into this session, I just want to say very quickly, because we're going to be wrapping up and you'll all be leaving, thanks to all of you, thanks to all who have been, my team and others who have been helping to put this together. In fact, if you would join me in a round of applause for all those who have helped to put this program together. There are many wonderful folks who've had the little staff badges on with the Edge of Change image of the painting. I think that this year's symposium, I know I'm a little bit biased, was extremely timely and wonderful, and we had a great mix of speakers, and we think this is a wonderful opportunity for us to close with a perspective of what's going on within our state. There's a lot of wonderful work being done. We actually are putting collective impact into practice. For those who are involved with the Birth Outcomes Initiative, if you go back and think about how that's evolved and how it's structured, and you think about the collective impact model, that's happening in real time. If you look at the work we're trying to do now around obesity prevention in our state, including childhood obesity, we're trying to do that same thing. The Coordinating Council work, which more globally is setting priorities for what we need to do to create a healthier state. And as we all know, we have great opportunities to become healthier. And our goal to not be the healthiest state, because we couldn't convince the other states to stop doing anything. And when you're 43rd, there's a little bit of room, but we could have the most improvement in the next 5 years. So as we do all of this work, I think this is a great way to close, and I'm very pleased to introduce Judi Gatson. And we thank her for being here today to moderate our Meet the Press panel session. I told her the only thing we didn't have was the dramatic music. If you ever notice these shows on Sunday, Meet the Press, Face the Nation, the music always indicates this must be a very important show and some very important topics that are going to be conveyed. And I know you will be hard-hitting with our panelists, not let them off the hook. But Judi, I will tell you, I live in Charleston. When I'm in Columbia, I always love to watch WIS and get the news from you. And anytime you want to come to Charleston, you can give those anchors a run for their money down there.
Thank you very much. Okay,
don't tell them I said that.
I was about to tweet it.
Okay. Take a picture of me saying it, Instagram. I'm sure you know all those nice folks down in Charleston. Judy's the anchor of WIS-News live at 5, live at 6, live at 11. You're thinking about any other hours you would like to do that,
yes.
Let us know. She's an award-winning journalist on topics ranging from education to consumer issues, and has reported on some of the biggest stories around the state. I bet you've even interviewed my brother, Sheriff Lee Foster. So
we've got breaking news in Newberry
County. I know
County
you do.
Right now.
Yeah. I tell folks in 45 counties I'm Dr. Foster. In Newberry County, I'm the sheriff's brother. And he's always on the news. We found out that anytime anything's happening, all of a sudden he shows up. So Judi is very involved in the community and served on the boards of Healthy Learners, the Palmetto Health South Carolina Cancer Center, the Palmetto Center for Women, and United Way's Palmetto Society. Please join me in welcoming our moderator today, Judi Gatson.
Thank you, thank you. I am really excited to be here with you all today. Over the last, year or so, we have covered healthcare more than any other time in my almost 20 years at WIS. And so part of the reason I wanted to be here today was to learn myself from the great group of panelists that they have assembled for the conference today. So I hope that you find it enlightening as well. We want it to be interactive, and if you have any questions that you'd like to put to the panelists, we will have a microphone that's available to roam around the room, and so just raise your hand up, very informal. We want to make sure that when you leave here that you have the answers to the questions that are most pressing in your mind. Let me just start by giving you a brief overview of kind of the goal and purpose of this particular panel discussion this afternoon and some of the important topics that we're intending to cover. As you know, healthcare nationally and also, of course, at our state level is moving beyond the walls of hospitals. Traditionally, healthcare has been viewed as a very hospital-centric model where the bulk of the care is provided after an acute condition has occurred, with treatment provided, of course, in an inpatient setting. So many times, I don't have to tell you all, I'm kind of preaching to the choir, that acute condition was brought on by a behavioral choice, which in many cases is very preventable. So with the passage of the Affordable Care Act, which essentially expands access to the right care at the right time in the right setting, at least that's the intention that we're hoping to see as it is implemented, we are gradually seeing a shift in that hospital-centric model. Right now, there are significant efforts underway to better connect the hospital with the community. So we're embarking on a new model that is based around continual engagement with patients versus reaction to an acute illness, because it's been proven that there are many, many ways to impact a person's health and their healing. So success, of course, for any healthcare provider, including hospitals, will rely on collaboration. Communities cannot do this alone. And cannot fix the problem. Hospitals cannot fix the problem alone. But in working with collaboration, we absolutely can bring about meaningful progress and innovation. So our panel today includes subject matter experts who are conveners, they are connectors, they are centers of influence, who really have a story to share. Their experiences come together, in fact, to tell a great story about what is ahead, particularly here in South Carolina, as we see these best practices implemented. So let me give you a brief introduction. I'm sure that you are already familiar, and I'm told that there is a full bio for each of our panelists in your program, but just so that you have a point of reference as we start our conversation this afternoon. To my far right and to your left, we have Amy Pickelsheimer, MD, who's with South Carolina Birth Outcomes Initiative. She's the clinical lead, I should say, in the South Carolina Birth Outcomes Initiative, a statewide effort to improve the health of mothers and newborns across South Carolina. Next to Amy, we have Eleanor Dunlap, who's a professional consultant with 17 years of experience in organizational planning and project development, working primarily with nonprofit organizations and community groups to strengthen capacity to achieve a common goal or mission. And seated next to her, we have Rosalind Goodwin, Vice President for Community Engagement for the South Carolina Hospital Association. She serves as the association's primary link with policymakers, community and advocacy groups, and also insurers and employers. And to my left, we have Graham Adams. Dr. Adams serves as the Chief Executive Officer and provides overall supervision and direction for the South Carolina Office of Rural Health. And to his left, we have Mr. David Porter, who is Director of the Abbeville County of Emergency Management and leader of their Community Paramedicine Program, which trains paramedics to help patients manage their chronic diseases and access community resources. And to his left, we have Renee Romberger, who is Vice President of Community Health Policy and Strategy at Spartanburg Regional Healthcare System. And last but certainly not least, we have Lisa Ware-Ellington, President and CEO of the South Carolina Business Coalition on Health, which brings decision makers, national experts, and data resources together to address the practical issues that impact our healthcare today. Let's give our panel a big round of applause. As I mentioned, we want this to be very interactive, so if you have a question as we're covering these topics, feel free to raise your hand. We'll also try and leave time at the end for Q&A there as well. Amy, let's start with you. If you would be so kind as for our audience to define the structure and the purpose of the Birth Outcomes Initiative.
The Birth Outcomes Initiative was sort of originally created by Medicaid, and they brought in a number of stakeholders in maternal child health in the state. So that's one of the most exciting parts of it, is to see how many people have come to the table. So the South Carolina Hospital Association has a very strong presence, as does the Department of Health, and Medicaid obviously is there, March of Dimes. You have a number of other community partners, all the major academic medical centers, and a lot of the smaller hospitals are at the table as well. So the original goal of the group was to try to decrease the number of NICU admissions and low birth weight babies in the state. So really to have a concrete, immediate impact on improving health of newborns.
And have we seen that progress in recent years?
Yeah, the Birth Outcomes Initiative is divided into 5 different work groups, and the first project that came out of the gate was to look at limiting elective deliveries that were happening prior to 39 weeks. And by just helping physicians hold the line about encouraging their patients to wait for 39 weeks has really made a big impact on the number of NICU days that we've seen in the state. It's very exciting to see that happen. There were examples in other states where a small group of hospitals had rolled out the collaborative with success, but we were the first state where all the delivering hospitals agreed to limit early elective deliveries, and that was backed up by reimbursement changes from Medicaid as well as the private insurance groups. And we've really, I think, had a lot of success with that in the state. We're a national example because of that. And this is all just volunteers coming together to work under the umbrella of Birth Outcomes Initiative. So a lot of people in the state working really hard to make an impact.
Well, that was no small feat because, and we've covered stories about that in the news where that was, just the big thing, and people started to realize the impact that it had on health and birth outcomes. So to be able to have that accomplishment and something good to report in South Carolina.
It is. It's very exciting.
It is pretty exciting.
Yeah. And this was relying on data
Yes.
to drive change in the healthcare system, and we really saw a good result from that as well. So.
That's outstanding. We understand the concept of no work, no pay for physicians. So how do you get physicians involved in this type of work?
You know, the 39-week initiative in particular was a great example where we had very clear guidelines from our national organizations saying that early elective deliveries were not the right thing to do. But there was a little bit of behavior changes that needed to happen to hold that standard. I think physicians were feeling pressured from patients to deliver women earlier out of convenience, and if they weren't going to do it, the patient was going to switch to another practice down the street. They were doing it for convenience for their own schedules if they were going out of town or had a patient they really had a connection with that they wanted to deliver. And once everybody was held to the same standard, it was really much easier to implement that than I was anticipating. There was very little resistance from physicians for this, and the non-payment really has not been an issue.
Well, and you talk about little resistance from the physicians. How difficult was it to bring patients along? Because it's amazing to me. We'll wait in line for concert tickets and Black Friday sales, but we're talking about something as important, as delivering a healthy baby, and people are so impatient.
And I think one of the advantages the physicians had was that they had professional organizations that were representing them through this process. We have the South Carolina OBGYN Association and the Association of Maternal Fetal Medicines that were in the trenches advocating for how this change was going to happen for physicians. But patients aren't always that well represented. And I think individual patients really rely strongly on their relationship with their providers. So we were grateful to have some of the input from the Department of Health and from the March of Dimes that had some really strong patient education materials out there. But I think a lot of this was patients getting new recommendations from their physicians. It happened one-on-one, and it's still happening every day, one-on-one in exam rooms. So it's ongoing.
Those relationships are important to build and help contribute to those good outcomes. David, let me come over to you and talk a little bit about the paramedicine program. It is an example of rethinking community assets to take better care of your local community. Describe for us what the paramedicine program does.
Okay. The biggest thing that we're doing is trying to rethink how EMS is viewed in a community. Typically, we've been seen as a transport provider. So you call 911, an ambulance is dispatched to your home, they arrive. You have one of two options when they get there. You can elect to get on our stretcher and be transported to the hospital, possibly some sort of an alternate destination like an urgent care if your community has one of those. Or you sign a waiver saying that, hey, I called you, but I'm fine now. I don't want to go to the hospital. And then we're released of liability, we're out of your lives forever. There's a lot of patients that are in between needing to be transported to the hospital and needing to just have a paramedic come out and say, do you want to go to the hospital? And so what we're trying to do is, use community resources, the medical knowledge that these paramedics have, as well as the relationships that they already have in the community, maybe with nonprofit groups, faith-based organizations, whatever the case may be, to get resources for these residents. It's interesting. The easiest way, I guess, to describe it would be a scenario. So at 3 o'clock in the morning, diabetic patient, uninsured, no primary medical home, loved one wakes up to find them pale, cool, diaphoretic. They call 911, an ambulance is dispatched, paramedics get out, they check a blood sugar, it's 30. They start an IV, they push D50, the patient wakes up, their blood sugar comes up to about 80, and they say, they eat a little something, they say, hey, I don't want to go to the hospital. Typically, we'd say, okay, are you sure? They'd say yes. They'd sign the waiver, and then we'd leave. Or we'd take them to the hospital. What that patient needs is diabetic education. They need just-in-time diabetic education training there in the home at 3 a.m., and they need to be referred into a diabetic education program. So our community paramedics have done clinical times with the diabetic educators. They've got diabetic educational materials in the quick response vehicle that they go out and see these patients in. So we can do that right then, and we can send an email to the diabetic educator and get that patient scheduled to go in and see them. So it's really a holistic approach. And also, I've just got to say that EMS has not typically done a good job in this state of integrating with the healthcare community. So it's also about further integrating EMS with the healthcare community overall. And again, not just being that transportation provider, being a healthcare provider.
When you talk about partnerships with other organizations, you mentioned, I think, faith-based organizations, how has that worked, and how has that been useful to you?
Well, it's been huge. The United Christian Ministries of Abbeville County operates the free clinic. It's open on Tuesdays. We'll have our community paramedics down in that organization. If they go out and they see a patient that needs a pill minder, they'll work with either the hospital foundation or they'll work with UCMAC to get that for that patient. They'll go out, they'll teach them how to set it up, and then they'll go check on them 2 or 3 times to make sure they're using it properly. Maybe do some medicine reconciliation or whatever the case may be. Let's say that we get called to a 911 call for maybe an elderly patient that was just recently returned from the hospital with a stroke, and they're having difficulty moving around their home. They'll do a home safety assessment, and if during that home safety assessment they decide, hey, you really don't need to be going up and down these stairs, they'll work with one of the local Presbyterian groups to have them come out and build a wheelchair ramp, or make some safety modifications of the home, maybe putting grab rails in the bathroom or whatever the case may be.
That's outstanding. When you talk about, and I think about paramedics, and you talk about calling 911 and they rush out, it seems like they have so much on their plate that they're dealing with already. Was there a culture shift or change that had to be made within the organization to get them on board with this whole idea of now not only coming out and providing that immediate care, but also providing this education and filling that role, or was it well received?
It was well received. I wish I could tell you that we're there as an organization or we're there as a community nationwide, but we're not. We're doing a 3-part rollout with a crawl, walk, and run phase.
Okay.
So we're just
That's
transitioning
smart.
from
Sounds
the
good.
we're just transitioning from the crawl phase to the walk phase, where we have the paramedics on 7 days a week for 12 hours. So they're going and doing the home visits as well as some 911 scene response. But it's tough, You're not going to take a paramedic that comes to work every day. Not that paramedics want bad things to happen. We just want to be there when stuff happens so that we can help.
Kind of like the news.
Yeah, exactly. But you're not going to take the paramedic that came to work to run that cardiac arrest or to run that gunshot wound, or that wants to face the car 30 feet down an embankment with an entrapped mother and a child. You're not going to get them to go into a home and sit down and do diabetic education for 30 minutes.
Right. That's what I was getting at.
So,
yeah.
What kills me is when one of my paramedics comes into my office and they say, David, I'm going to nursing school, or I'm going to PA school, or I'm getting out of EMS in general. There's absolutely nothing wrong with that. But when they tell me they're doing it because they just can't work on an ambulance anymore, because at 3 o'clock in the morning going into a single wide trailer to heft a morbidly obese patient out is very, very tough on the body, and they can't do it for long. In law enforcement, in healthcare, in the fire service, you can go work vice, you can go work narcotics. You can move from a line firefighter to a fire officer or a battalion chief. Healthcare, you can go from nursing to an administration position, quality position. In EMS, you're a street paramedic or you're a director or a deputy director. That's it. There's really no upward mobility. And so I see community paramedicine as a way to keep experienced medics out on the street. Not only are we just doing these home visits, but we also use the experienced community paramedics to respond to the high acuity calls with maybe a younger paramedic. So if they're in the middle of a very chaotic cardiac arrest situation, they can come in and maybe put a calming hand on their shoulder and say, hey, have you tried this? Or, let's take a step back. So it's beneficial to the organization as a whole, and I think that we're really starting to see the value now.
That is outstanding. Yeah, Graham,
If I could.
interject.
And the great thing about the model is that they're practicing within their current scope of practice.
Yes.
So there's some additional training, but there's no additional certification, and there's no new classification of practitioner that needs to be developed. They're practicing up to the highest level of their certification. So that's one really exciting thing that we've seen about the work that David's doing, and in different places throughout the country where this model is being used.
But David, how are you getting paid?
That's the big question, and we're still trying to figure it out. So one of the things, I do want to recognize 3 people that are here, particularly Melinda Merrill, Sarah Mathis, and Mary Margaret Jackson from the Office of Rural Health that work with Graham and the hospital. They were kind enough to help us apply for a Duke Endowment grant. So right now we're living off grant dollars. We are working furiously to try to show our data, to show our value. I think there's there's a couple different ways in which we might be able to be reimbursed, whether it be a relationship with the hospital where we go try to keep someone out for 30 days. If we do so, then we get paid on a fee-for-service basis. Or if we're able to show value in improving patients' outcomes, we might be able to change some of the current models.
That'll
That's a
take
big
some
question.
time, but it's an investment worth making. How far is this model in terms of, you all are in Abbeville. Is this widespread across the state right now, or are you all really kind of leading the way in being trailblazers here to set the standard for everybody else in South Carolina?
I don't know if we're necessarily trailblazers. We are the pilot project for the state of South Carolina. They're
That's
looking
trailblazing.
at
Yeah, it's trailblazing.
Yes,
That qualifies.
But we're the pilot project. There's a lot of folks that are looking at getting into this. The South Carolina Office of Rural Health, Sarah and Melinda, have published a fantastic document called the Community Paramedicine Blueprint for South Carolina. They presented at our South Carolina EMS conference, very well received. I'm sure they received more phone calls about this than I do, which is a lot. So I think it's something that folks are starting to realize, but the bottom line is that healthcare is changing. And now's an opportunity for EMS to integrate. We're calling it community paramedicine. Nationwide, it's starting to get dubbed mobile integrated healthcare because we're strategically deployed in the community. We go out and provide healthcare. We shouldn't be viewed as a transportation provider, and we shouldn't be viewing ourselves in that same way.
Thank you very much. Eleanor, let me come back over to you. We'd like to have you talk a little bit about the grassroots movement for healthy eating and active living here in South Carolina. Give us a little bit of an overview.
Yes, thank you. And I'm going to be speaking as a representative. I'm the chair of the board of Eat Smart, Move More South Carolina, a nonprofit organization that partners with many of you in the room to ultimately make the healthy choice the easy choice when it comes to good health and nutrition and physical activity in our state. I'm also speaking from 4 years of experience actually managing and growing a collective impact effort in Greenville called Live Well Greenville that has been very successful at basically implementing the model that Laura shared earlier in terms of having a backbone organization. So that's kind of what I'm bringing in terms of perspective to this dialogue today. In South Carolina, Eat Smart, Move More is actually working with about 40 local coalitions throughout our state to bring multiple stakeholders to the table to really look at common agenda of obesity prevention and collective strategies to address better access to healthy foods and physical activity. So the coalitions are working to work with workplaces, work with schools, work with hospitals, municipal and county governments, recreation providers. So we're seeing momentum both at the local level and across our state. And last year, I think when Director Catherine Templeton convened this unified movement, we saw hundreds and hundreds of stakeholders coming to her first meeting who were very interested and invested in this work from the local level to the state level and actively engaged in ownership within their workplaces, within hospitals, within municipalities. So the movement is well underway in South Carolina. I'll say the degree of success is still varies from community to community. In some communities, such as Greenville, where resources are much more available and expertise, there's been a great deal of success. In more rural communities, there are early successes that build momentum, but resources and expertise and technical assistance is greatly needed. So Eat Smart, Move More South Carolina is providing technical assistance and support to those local communities, mining best practices and helping communities to implement them in South Carolina.
That's outstanding. I was looking over the agenda, I guess, in the program for even the meeting today, and the mention that the menu, what you all have been eating are the healthy, easy choices and options, and the encouragement to get out and walk, between the sessions, and I hope you guys have been doing that. But talk to us a little bit about some of the recent obesity statistics here in South Carolina. I mean, we know South Carolina is really has an issue with a lot of health disparities, especially in rural communities, as you touched on, but everything from the age of onset to health risk and complications and even the cost of care.
Sure. And I'll steal from Director Templeton in that if there's one issue that we can try to address in South Carolina that would make the most impact, it would be obesity and overweight in South Carolina. 3 of 5 adults are overweight or obese, and South Carolina is third in the nation in terms of childhood obesity, with a rate of 39.2% of youth ages 10 to 17. 1 in 4, this is another way to look at it, 1 in 4 of our young adults actually cannot participate in the military because they were overweight or obese. Basically, the risk factors, obviously, that are most prevalent in terms of obesity are nutrition and physical activity. 4 out of 5 South Carolina adults don't consume the recommended daily allowance of fruits and vegetables. And half of all South Carolina adults are considered sedentary. Obviously, our kids, when you look at the forces against good health and well-being, our kids are much more sedentary with computers. I loved the video, Let's Work to Work Harder, because it really did describe the barriers to good health that we have before us. Obese adults are at greater risk for high blood pressure, high cholesterol, stroke, gallbladder disease, gastrointestinal complications, respiratory complications, sleep apnea, and that doesn't even address the mental health issue of depression and stress that often comes from adults and children who are dealing with overweight and obesity. Unhealthy diet and sedentary behavior accounts for approximately 300,000 deaths in South Carolina each year. The costs to our state are estimated based on DHEC's obesity burden report, over $1.2 billion in obesity-related illness, and that is actually expected to increase to over $5 billion by the year 2018. So it's right around the corner. If we don't tackle this issue, it's going to continue to cost our employers, our large employers. It's going to continue to cost us in terms of economic development and recruitment of industry to our state, which I hope Lisa will address shortly. And it will cost us in terms of academic success of our children and a healthy, prepared workforce, not to mention life expectancy.
Several years ago, and it had to be at least 2, if not 3 years ago, First Lady Michelle Obama visited, and I covered her visit at Fort Jackson, and people were wondering, well, why is the First Lady at Fort Jackson? They thought it was about encouraging and supporting and reaching out to military families, particularly military spouses, but she was there because of this problem of obesity. And the issue of new recruits coming into Fort Jackson and the rate that they are now dropping out of basic training due to problems with bone breaking during basic training because they're not getting the calcium and nutrition that they need due to obesity, and the Army having to continually drop their standards, and the exponential rate that the budget has grown in terms of treating those injuries and those surgeries, it was astounding. And in a very real way, I realized from her presentation that it is impacting military readiness. We may not see the full impact of that right now, but we certainly will down the road.
Well, and not to mention our own public safety. When you look at the ability for firefighters to be prepared to respond and first responders, that touches us right in our neighborhoods, right in our communities each and every day. So we are going to have fewer and fewer individuals who are going to be prepared for our police force and emergency responders.
Well, David, that's what you talked about earlier, that when you referenced obesity, when a paramedic goes in, and you don't think about that. I mean, you think about them just being trained to respond and be the first responders to show up with the courage and bravery to deal with whatever the situation is, but the physical strength, and like when you talked about earlier of being able to remove, an obese person from a home or deal with that situation, it takes a physical toll on the body.
Absolutely. And to touch on what you were saying about the preparedness of the workforce, that's a huge issue. That when I talk to sheriffs and police chiefs and fire chiefs, they've even had to drop their standards as well, especially in rural communities. where it's tough to recruit and retain qualified employees as it is.
And as a taxpayer and someone who lives in those neighborhoods, that makes me a little nervous that someone might not be able to respond adequately to my needs.
Let me ask you this, Eleanor, and I don't want to get political, but this is a real issue. When going back to the First Lady's visit, I said, well, gosh, who can take issue with that? But we got a number of emails at the station, even the whole Let's Move initiative. I mean, why is that not a good idea? But because of the political climate that we're in right now, a lot of people take issue with, quote unquote, the government trying to tell us what to feed our children. I mean, most of us, I think, view it as an education type of thing to make healthier choices for our kids, because let's face it, a lot of children, I know that there are some health issues that can lead to obesity, but many of our children are fighting this challenge because of what adults put in the home and make available to their children. So how do we break through that to get everybody on board with this initiative and understand what it's costing us in terms of the cost of health care, military readiness, first responders, and the list goes on and on?
Well, I think this issue truly crosses the political lines, because when you look at the issue of job readiness and being a community that really promotes economic development and jobs as being the avenue to prosperity, it's affecting employers. And it will, if we don't address this, employers are already looking at the health of the workforce, not just the type of skills that our workforce is prepared for, but what is it going to cost us to relocate to South Carolina in terms of our medical care. So they're also looking at not just the clinical services and the treatment and the cost of care, but does this community actually promote healthy behaviors? Are our communities, in terms of quality of life and physical supports, do schools offer healthier meals? Do communities have parks and trails and greenways that are being used by their employees to stay healthy? Are there centers that really are available there to promote fitness and good health and well-being? So that speaks to a bipartisan approach, in my opinion. And I think that this is an issue that would get people to the table. Now, the other issue is what kinds of strategies would promote bipartisan support, and those are the strategies we need to focus on first. The ones that are going to really attract a collaboration between Democrats, Republicans alike.
Well, I think the whole issue of the Affordable Care Act, and that changed the political climate dramatically, but now that we've moved past the point of implementation, maybe the focus can be back on health, and we'll see more of that bipartisan effort to move some of these initiatives forward. Renee, let me come over to you. We'd like to have you talk a little bit about the hospital's expanding role in the community beyond providing traditional health fairs and expos. We see those out in the community a lot, but truly getting into doing an environmental scan of the health status and the needs of the community.
Thank you. I think it's an interesting time for hospitals because we've evolved over time, and we did in the 80s decide everything was about doing a health fair. And if you did your health fair, you could check that off the list. You've done your duty, you've done your moral responsibility, and life is good, and you move on. And then in the 90s, we changed again. In the 2000s, we changed again. And where we are today is a place where everybody, if you're a nonprofit hospital, you have to answer to the IRS. You have to say, I can provide community benefit. So you have to be demonstrating how you give back to the community. And I get so frustrated with that phrase, how are you going to give back to the community? Because I think the important lesson for us in hospitals is community health, population health, whatever you call it, it's not a give back strategy. It's a business strategy, and you have got to integrate it into your hospital system. We looked at, for our hospital system, how much we were spending on charity care 5 years ago. We were at $116 million. We knew that we couldn't sit still and ignore that number. Historically, we had said our mission is to care for everybody in the community. If you walk in our door, we'll take care of you, and we're meeting our mission. But at some point, when you look at that dollar amount, and I think it does cross the Republican-Democrat boundary because it's not a political issue, at some point our community, our society can no longer afford the healthcare system that we have.
Right.
So at 116 million, we oftentimes laugh and say, okay, if I gave Lisa a $116 million check and said, make people healthy in Spartanburg, wow, wouldn't she be successful? But yet we were sitting back as a hospital and just opening our doors for all the crisis patients to come through, all the folks to come to our ER for primary care, and not recognizing that we had a responsibility outside the four walls of the hospital. So for us, it was a matter of, first, let's figure out who needs to be in the discussion. I think one mistake we quite often make is we're going to hire somebody to be the community health person. Here, you go be the community health person and go out and change the world. Community health is not a one-person issue. It's not a one department. It is a hospital philosophy and commitment. And if we're going to be successful as a hospital, and I bet every hospital in the state of South Carolina is part of your mission, it's to improve health. Well, if your goal is to improve health, then you've got to have it hardwired into your system. You've got to have a commitment across the system. How are we going to improve community health across the board? So my suggestion first is, before we go out and say, here's our community health strategy, that we look internally inside the hospital. First, we need to form a team. Who all needs to be a part of the team? For me, when we were doing that at Spartanburg Regional, one of my favorite team members was the head of the EMS. They see it every day, yet somehow when we're thinking about strategies, we never bother to ask them and include them in the conversation. Another one of my favorite team members are the case managers of the world. Goodness gracious, they can give you the solutions right off the bat, but we've somehow never included them at the table. So I think goal number one would be figure out who sees it every day. A physician who's a hospitalist, another great team member to put in there. They can tell you stories of why they're failing. And so if you get people in a room and you say, what could we do in the community that would make your life easier and more effective inside the four walls of the hospital, that's where we're going to be successful, because they can answer that question for you. The nurse who works in the ER can say, wow, if you would just do X, Y, Z, we could do a better job inside the emergency room. When we started asking those questions, we heard tales that were embarrassing to us, things that we should have known that we didn't know. But it also, when you bring those people to the table, you start putting the pieces of the jigsaw puzzle together, and you start to see, here's how we can get involved in the community. So I think that's our first step, is build that team, get commitment at the top that community health, population health is a system-wide strategy, should be part of your strategic plan, and then take the time to go get the data. All our data friends out here, whether it's Joe Kyle or Annika Moonen or Ana Galejo, they understand the power of data, and we've got to let that data drive what we're going to focus on, what we're going to be committed to. Because if we don't understand the story, oftentimes we're spending our money and our resources chasing a symptom and not a root cause.
Talking about spending money and resources chasing a symptom, going back to the pilot program that David's department is leading, how do you think hospitals value the service, really, that they are providing, and do you think hospitals would be willing to help with the issue that you brought up of how to pay for it?
Historically, I think we think episodically in hospitals. So we think that our responsibility, what we do in our department, no matter what your role is, that I'm the beginning and the end. When you come to see me in my department, I have done my job when I take care of you, and then you leave and I'm finished and I'm done with you. And so somehow it gets back to that getting everybody at the table and having that dialogue beyond, this is my department, I work in the lab, this is what I do in the lab, I work in the ER, I'm going to take care of you in this moment, I don't know what's happening to you before you came in or what happens after you leave. But I loved what David said that just makes me go, if we could all move to a level where we commit that we're never done, we're not the beginning and the end, but that our role is, when I'm finished with you, I'm going to hand you off to somebody. Theresa Seberg and the folks at our QIO have really taught us a lot with a project we're working on to reduce readmissions, that reducing readmissions isn't about changing what you do inside the hospital, because patients are bouncing from hospital to hospital. If we're going to reduce readmissions, it's about me understanding the hospital in Gaffney and the one in Union, because that's where our patients are going. They're bouncing between our hospitals. And so we've got to have that dialogue. We've got to talk about how can my discharge summary mirror your discharge summary, and you're my competitor. But I need to work with you to do that so that when the patient doesn't fall between the cracks. And I think the future to improving health is really about handoffs and understanding and getting to know your partners and the role that each one of us plays. And EMS is a critical partner, and they have downtime. And I love the fact that he's built this program so that he can utilize his folks when they're not out saving that heart attack. They see it. They know that person's going to fall down those steps. But yet if they didn't take ownership of that, the incident, the accident's going to happen, and nobody's going to do anything about it.
Well, I think any reasonable-minded person thinks the whole idea makes great sense, and it's providing a critical service, and it can have, when you look long-term, some wonderful outcomes and a big impact. But do you think hospitals, I guess, would recognize that, but do you think they'd be willing to share the cost? I guess that would be the big question.
So that is a very, very hard thing to do. It is very hard to sell. Mr. CFO, I would like for you to invest $185,000 a year for Well Vista, which is a pharmacy program. And we spent a long time having a dialogue inside our hospital about are you willing to spend to save? I had a conversation with Tony Keck on Friday, and he said, why do you think it's so hard to sell? And I'm not sure. I don't know if it's left over from the 80s where we did health fairs and everybody invested in wellness, but they didn't really see outcomes, and so everyone went, not doing that again. I don't want to invest in prevention and early intervention. I need to spend money when people come in the door. But we've made a commitment that we track everything we do, and if we can't improve health and reduce the cost of care, then we're not going to do the project. So there's a way for him to show that he's saving money. For us in Charity Care, 5 years ago, $116 million. Last year, $81 million. We've dropped $35 million because we've been willing to take some of the money we were spending and invest it in things like his program. How can we support these prevention programs that will allow us to save money? Because we're spending the money right now, and we're billing it to our friends, the employers. They're footing the tabs for our lack of engagement in trying to solve these issues upstream.
Well, go ahead,
I'm sorry,
David.
if I could just tag on that, she mentioned collecting data, and that is absolutely crucial, especially when you're trying to show cost savings. Because if you go out and try to talk to a CFO, it's very easy to show a new revenue line. You know, if we do XYZ service, we're going to be able to build this. I think we could drive this many patients to it. But when we're talking about improving the quality of someone's life, you know, that's very, very tough to show. That's something that Melinda and Sarah and Mary Margaret and I talk about all the time, because we go out and we'll see a patient and we'll just, we'll get them hooked up with housing. We've got a relationship with the housing authority to where they know when we call, this is something that needs to happen. So they go on the top of the stack. We'll try to get them in with the financial counselor. So we'll pick them up in the QRV, take them to the library, make photocopies of their birth certificate, their social security card, take them over to the hospital where they'll meet with the financial counselor. We'll then go back to them and say, did you receive that letter from Medicaid yet? And they'll go, yeah, it's right here. And we'll say, okay, you know what we have to do now? Get in the truck. We're going to the hospital. And it's not just about making those warm handoffs or making the connections, but sometimes it's about circling back around to make sure that the process worked.
Right.
Because that's where it breaks down, I think, so often for folks.
And to being able to substantiate that. Ladies, did you want to add something, Eleanor?
Yeah, I just was going to say about discharge and spending money. You know, we spend billions of dollars on treatment and even extended care, but we send patients back into the toxic environments that really don't support the treatment regimen. And then they're back in, and they're back in. So that's where we see the repeats.
You have to try and break that cycle. Lisa, that's a great place to bring you into the conversation, a great segue there. What do you see as the areas where business, in the business community in general, is willing to collaborate with providers and stakeholders for health-related matters, but they're seldom called to the table?
I think that employers, and we are an employer-led coalition, really have suffered and paid the bills, as Renee said, for many, many years without feeling like they were being supported by the healthcare system. So therefore, they have had to delve into healthcare even though they make cars for a living, for example. So, they've created on-site clinics and brought other services in-house, but they're more than willing to collaborate. I think they're looking for solutions and partners in the healthcare system. And I queried them before I came here just to get some input to give you. And they're looking at things like high performance networks. Who are those high value providers? Direct contracting for bundled high cost, high frequency procedures. Outcomes-based payment models, EMR, data integration, some of those sorts of things. That's what they're looking for, that they don't want to have to go it alone, but I will repeat something that Camille Reams from BMW told some of us yesterday, and that's that BMW cars used to have just steel bumpers on them or metal bumpers on them, and then they started to paint those bumpers so they'd be the same color as the car. And the outside vendor cost so much that BMW brought that service in-house. And surprise, surprise, it finally drove down and gave competitive pressure, and they were able to outsource it again when the pricing came down. I think the same ideas can be applied to healthcare. Employers feel like they have to do it themselves until they have another alternative.
Let's flip the script on that same question a little bit and take a look at the areas where the business community is constantly called to collaborate with other health stakeholders, but there's little clarity on why they're at the table.
I think that they're really not constantly called, to be honest with you.
Really?
I think that more what they don't like are the vendor approach, where you're coming in to sell them something in a little silo that's not integrated with their full strategy for healthcare improvement. So I really don't think, just from the group I work with, that they're called to the table that often. I think they want to be.
So maybe that's part of the issue. They want to be.
I think so.
But what areas do you think that they could have an impact?
Our groups are very interested in improving systems of care, things like patient-centered medical home models. All the folks around the table are people that we are already starting to partner with more and more, because employers have been in that silo, and they really don't know the resources that are available in our state and the work that's being done in our state. And I've been very fortunate to get to work with Dr. Foster, the Hospital Association, the Health Coordinating Council, and the Obesity Group, and really learn what those resources are and who the players are in the state and how can we work together and what is that common agenda. And as far as collective impact, our coalition is that backbone organization. That's what we focus on. That's all we do. So we're able to convene when needed. We're able to bring outside experts in when needed, and we're able to really drive that agenda forward. And I feel like employers, for the first time in my 30-year career, are really willing to climb in the front seat and start to drive that change.
That's encouraging. Dr. Adams, you wanted to add?
I did. Lisa, how much do y'all really discuss transparency and the fact that you're the ones often paying for the care, but you don't know what you're buying up front, and often when you get the bill, you're not even clear what you paid for?
That is a terrific question, and that is one of the foundational points of the coalition. More and more employers are going to high deductible health plans. The jury's still out on how that might work out, but what we have found is we can't get information to those employees to make those decisions when they have a $5,000 deductible on what is the most cost-effective and the highest quality solution for their particular problem. Now, we are regional rollouts for Leapfrog, and Leapfrog is a national initiative on, it's mostly patient safety, but there are some quality metrics in it as well. We produce 50,000 quality guides every year that we distribute not only to our members but to libraries and out throughout the state. Is it the best solution? Not necessarily. There's no cost data in it, but I will tell you this: it's the only solution that we can find that is easily accessible, that we can print and put in the hands of that employee. So we need to evolve that, and we're going to be talking about that. Dr. Foster is going to visit with our board next week, and that's the topic, is talking about quality initiatives, data, and transparency in the state, and the tremendous need there is in the employer community and the employee community to have that level of understanding to make the good decisions.
Thank you very much.
I think physicians are just getting that kind of data too. I think this is kind of the era of big data, and we have a data team with Birth Outcomes Initiative, and they just sent out report cards to the hospitals showing their rates of cesarean section and the early elective deliveries. And the response has been surprise. I think people had no idea how they were doing compared to other hospitals in the state, and I think there's already some momentum just from regular doctors on the street to pull their numbers in towards the mean. I mean, they're sort of competitive people as a group anyway, but it's great to have that data. I mean, as a doctor, I had no idea what my C-section rate was until this came to our hospital, and then they broke it out by individuals, and I was right on the mean, thank goodness. But it's great that we're finally having that kind of data, not just on the employer and the consumer side, but also on the provider and the hospital side. This is a cool new era for us. It's exciting to be part of healthcare right now, I think.
That's awesome. Rosalind, let's talk about the Working Well project. That's your brainchild. Describe the change levers used in the Working Well project, everything from policy changes versus high-cost changes, thinking differently, benefit design, and the pricing strategies.
Well, certainly, a lot of people are very familiar with workplace wellness, work site wellness. A lot of times, the first thing we think about is Weight Watchers challenges and those type things, really focused on programming. What Working Well seeks to do with the clients that we work with, about 100 across the state, is really help them to create a culture of wellness. And the way you do that is through policy and system change. Nothing wrong with programming. Programming is great, but without a foundation of policy, system, and an environment that helps to encourage that healthy choice being the easy choice, it just kind of breaks down. For example, you may be having sign up for a Weight Watchers challenge in the break room, but there's an employee appreciation dinner catered by Sheely's across the hall. It kind of defeats the purpose. So our association, our board, we had a very forward-thinking board chair about 6 years ago, Bruce Bailey at Georgetown Hospital System, really challenged us to say, we talk a lot about reimbursement, and we're very reactive to what's going on in healthcare in South Carolina. What can we do to be proactive to really impact public health and prevention here in South Carolina? So before we decided to go out and set out some other agenda to change the world, we just listened to the lyrics of an old gospel quartet song that states, "Sweep around your own front door before you try to sweep around mine." Y'all gonna YouTube that and listen to it on the way home, I know. But we kept hearing from our partners with Blue Cross and others that, hey, your hospital employees cost more money in medical costs than any other industry in the state. And then the national stats that came out that said that hospital employees have higher medical costs. Who would think? Hospital employees go into the ER more than any other industry. So we recognize that as an employer of 80,000 plus people in South Carolina, if we would just first focus on getting our own employees healthy and being the largest employer in almost every county and city in the state, what kind of impact could that start if we just first started with our own employees? And our hospitals do a lot of things, health fairs, and we're always trying to help the community, but what were we doing with our own employees? So we reeled it back in and said, you know what, we're going to focus on our own employees. For some years, we got the generous and support from the Duke Endowment. We got a seed grant from Eat Smart, Move More, and we really started focusing on just 3 areas. Nutrition, physical activity, and having people never start smoking or stop smoking. We started to assess through a web-based assessment how our hospitals were doing, how were our environments. So some of the things we're talking about outside of programming is we've got a number of hospitals and other clients we serve that have built walking trails. We have pricing strategies in our cafeterias. If you go into most of our hospital cafeterias around the state now, you're going to go in the cafeteria and you're going to see labeling. You're going to see different colors indicating which meal is the most healthy meal. We used to have hospitals that were known for the best fried chicken in the state. So we've got to change that culture. For example, you would come to the hospital association and come to a meeting. She mentioned the Work to Be Fit on our brochure. But we would have meetings. I'm not going to mention the name of the type of groups, but fried chicken, barbecue, rolls, banana pudding, macaroni and cheese, coleslaw. One meal in the middle of the day at the hospital association. But we've changed our catering policy, even at the association, to really lead by example. We're not even serving sweet tea anymore, and that was, whoa.
I saw in the brochure sugary drinks would not be readily available.
Yeah. So those type policy system changes, being able to have a policy that you can work out, use flex time at work to go work out. So all of those things really change the culture by changing the policy and environment, and it's very encouraging, and it's very easy for people to make that healthy choice the easy choice. We started hearing examples of hospital employees getting off of medicine, losing weight. We've got one of our mid-sized hospital systems that's telling us that they're saving at least $2 million a year because of working well, and the changes that are going on. So we've got hospital CEOs leading walks in the middle of the day. It's just really an exciting time, and we were able to take that model before, while we were focusing on ourselves, didn't recognize other people around the state were watching and said, wow, that's a great model that anybody could use. So now we're working with manufacturers, universities, municipalities. So we're just really excited about employers really taking a part in prevention and recognizing that, goodness, we spend most of our day at work. And if we can really change the culture there, we can really make an impact on people's health.
Rosalind, you touched on changing the culture. And I know sometimes these are difficult conversations to have, but in doing interviews about heart disease and Breast Cancer Awareness Month, and maybe breast cancer is not the best example, but when we're talking about issues that are related to how we eat and exercise and like I said, obesity, heart issues, diabetes, and things of that nature, I have had person after person after person to tell me, well, because the question is always, well, if you knew better, why didn't you do better? But, and just keeping it real, they'll talk about, their provider, whether it was a doctor or a nurse. Well, I looked at them and they were overweight or they weren't healthy, so why am I, listening to this person if I don't see that they're practicing what they preach? I mean, are they aware that they are having that kind of, I guess, maybe indirect impact on patient care?
Yeah, I don't think we are. I mean, there are a lot of reasons. We've all gone to a healthcare facility and seen a nurse in scrubs smoking. Scrubs and cigarettes should probably not go together, but they often do, and there are a lot of reasons for that. It could be stress, long hours, and those type things. But I think now we've got more of a focus on, now that our hospitals are focused on making sure that we're taking care of our most valuable asset, which is our employees, getting them healthy. They certainly are setting an example for their patients. We have a video on our website of one nurse at Baptist Easley. It's a wonderful story. A caregiver, of course, she's taking care of her own children, and she's taking care of countless patients in the Easley area, but just taking care of everybody else, she never took care of herself. But now, since the culture has changed in her hospital, where she comes to work and serve every day, where she has the choice for a healthy option. She has education about which meal to choose. She's lost weight and off medication. So those type things really have an impact that is not only impacting that employee, but it's impacting their patients as well as their family. Her family is now more active. So it's just amazing the change that could just happen with us staying in our own sphere of influence. What can I do and see that spread? It's amazing work.
And you talked about reaching out beyond the hospitals and now working with manufacturers, universities, other private businesses. How are those relationships developing? Are you all actively reaching out to those organizations? Are they coming to you? Is it working both ways? How are you making more of those connections?
It's kind of happening both ways, but because of the generous support, DHEC, I know I see some of our partners here. Our Department of Health and Environmental Control received a community transformation grant through the Affordable Care Act, and we were able to expand to at least 30 non-hospital businesses. And then now people are just coming to us to ask for our strategic planning help on worksite wellness and policy and system change. So a bulk of our non-hospital business has come through that grant funding, but we're certainly open for more. There are brochures outside. You can contact us. And then we're excited that this movement, involving some of the largest employers in the state, is attracting the attention of other industries. So, for example, there's a flyer outside about the Fit Family Challenge that we're partnering with some people, but that's an unlikely partner, but we're partnering with Coca-Cola and Parenting Magazine for a statewide Fit Family Challenge to start in mid-May. You'll hear a lot about it mid-May until July. But really helping families with expert advice, setting goals, and then driving that traffic to our hospital, health fairs, and all those other events we have going on to really help them get active and fit. And just using all these different resources and companies and having people come together and have really hard conversations about marketing and those type things too, but bringing everybody together for a very holistic approach to change healthcare in South Carolina.
Very exciting. And that I was wondering about the business component, because I know we have a lot of wonderful businesses in South Carolina who do truly care about their employees, but all businesses understand the impact on the bottom line. And if they're saving money through implementing these programs, it just makes sense. Dr. Adams, talk a little bit to the audience about the South Carolina Health Coordinating Council and the role and the mission here in South Carolina.
Sure. So the South Carolina Health Coordinating Council is it's really a coalition of 40-plus entities and thought leaders around the state that have come together to say, you know, we're tired of being ranked at the bottom of the health statistics nationally and both a lot of the counties within the state, of course. I mean, most recently we were ranked 46, I guess, least healthy in the nation. Now I think we're 43. So we made a little improvement, but a lot of for years our state has really worked in silos, and different folks have had very well-intentioned efforts to work on various things within their mission, within their scope, be it obesity, hypertension, heart disease, whatever it may have been, and it really didn't very often leave the walls of that institution or leave the walls of kind of that group of practitioners. And what the Coordinating Council is trying to do is really develop that common agenda for the state and say, you know, what can we collectively set as a common agenda and move towards? We have thought leaders from, you know, hospitals, physician practices, from community health centers, from Blue Cross Blue Shield, from the Duke Endowment, from Michelin and employers. Lisa, Renee, folks like that are very involved. And it's a way, again, to set that common agenda and then try and create strategies to try and address those issues. So really driven by data, in the last year or so, we've identified 4 key areas that we feel are going to most significantly impact our ability to move our ranking. And those are really mental health, obesity, perinatal issues, and what we're calling systems of care. And the way we're going about that is not by hiring a bunch of staff and going out and doing, because our partners are already doing a lot of that work. It's by trying to find a lead on each of those efforts. For instance, on obesity, DHEC has planted that flag. They said they are going to really put a renewed effort on trying to impact obesity throughout the state, not just with children, but also with adults. And we're using the work that DHEC is doing around obesity to inform the process that the Health Coordinating Council is doing. So the really interesting thing for me is that, you know, I've been doing this a while, and a lot of us sit on a lot of different panels, a lot of different boards throughout our careers, and, you know, it's one thing when the governor says you're going to do this, or the federal government says here's your mandate, go do it, or a funder, you get a big grant and they say go work on diabetes. Often when you do that, you're compelled to do it, and when the dollars go away, when the mandate's been met, there's no passion for it. The thing that's unique about the Coordinating Council is there is no mandate. There is no governor's edict saying you will do this. It's a kind of a moral imperative that I think the folks at the table feel like it's not good enough to be 43rd. It's not good enough to have these problems that so many of our folks suffer from. How can we, you know, move that needle collectively, and how can we set the agenda and then have the folks around the table and others say, here's what my entity, my association is going to do to fit into that. So it's not really, the council is really about, Dr. Foster has a kind of a 3-word phrase that makes a lot of sense to me. It's more convening, connecting, and catalyzing folks to move towards these common goals so we can try and, again, move the needle for our state. And I don't think you'll see the Coordinating Council hiring 20 or 30 staff. I don't think you'll see us embarking on huge campaigns to address various issues. What I think you will see is us planting the flag and saying, here's where our state needs to be. here's how the individual members and others throughout the state can help participate and get us to that goal. And we don't have enough resources to reinvent the wheel. We don't have enough resources to duplicate what somebody else is doing. Really just trying to make sure that we all are aware, we're talking, we're sharing, but we're also encouraging each other and holding each other accountable to say, what are you doing about obesity? What are you doing about our horrible prenatal statistics in rural communities throughout the state? And I think by doing that, so far, we've gotten a lot of interest. We've gotten a lot of organic movement, I think, to really make this work. So, we're on the front end of this, and it really takes years to kind of develop that collective agenda and to see the needle move. But I think the birth outcomes effort is the perfect example of there was no edict, there was no mandate, there was the moral imperative to do better. And by getting folks around the table without really any money, you made a significant difference. So that's kind of the model that we're using. Got a lot of the same players involved, and we're just very optimistic about the outcome.
You mentioned mental health being one of those key areas as well. How can we translate that same philosophy, that same thinking about kind of that moral ethic to be able to have an impact there to that issue that seems to be so tough to tackle? I mean, it is in the news every single day.
It is, and I think it impacts all of our families in one way or another. And the IOMPH, the Institute of Medicine and Public Health, is the one that is really taking the lead on that. They have planted the flag in that, and they have said we're bound and determined to really come out with some actionable recommendations around that within the near future. They're very engaged with the council. Again, much like DHEC taking the lead on obesity, the IOMPH is taking the lead on mental health, and by doing that, they're really working with the Department of Mental Health and a lot of different folks throughout the state to really identify, again, some actionable goals. The challenge there is there's so many issues around the homeless, around veterans, around folks in rural communities where there really are no psychiatrists. We've all heard the issues around folks that are showing up in hospital ERs, both urban and rural, and they're just basically being warehoused sometimes for weeks and weeks. And there have been some tangible outcomes. A telepsychiatry program has been in place in our state for probably 4 or 5 years now that has been a benefit to both the providers that work in those ERs, so they know better what to do with these patients, and also to the patients themselves, so they don't get in kind of a limbo where they're not really they're not discharged, but they're not really admitted, and they're just kind of held in observation in kind of a warehouse setting.
Well, and you're right. There's so many challenges in addressing that issue of mental health, because even as we talk about these different health disparities that we are dealing with, at least people are aware of them and willing to acknowledge them in some form. I mean, if you see someone having a diabetic seizure, people run to try and help. If you see somebody having a heart attack or stroke, people call 911. They jump in right away and try to help. But if you see someone that you think may be suffering from mental illness, that people are in denial, they ignore them, or they walk the other way and have no idea what to do. And so just even recognizing and acknowledging that, and then being able to connect to the resources is a huge challenge. But we've got to figure it out, because we're covering the shooting in Fort Hood right now, where in the military environment where there's plenty of access to care, still we're not able to figure out a way to really treat and deal with these issues in a meaningful way, in a preventative way, instead of again after the fact.
And so often it's EMS folks that are left
confronting with that, exactly,
to deal with this, and the patients they often end up either at the ER or at the prison, at the jail.
Exactly, where
Judi,
that's a whole other issue. Yeah, sure, go right ahead.
Just to add a comment about the behavioral health issues. I think that's why the South Carolina Health Coordinating Council and the local initiatives that bring everybody together to have the discussion about behavioral health is so critical, because it's not the Department of Mental Health's responsibility to solve this issue. And I think historically we think that's their problem,
that's just their deal,
their issue,
right.
But it affects all of us. And so through the Institute of Medicine and Public Health, who is now researching this issue of behavioral health and what we can do in South Carolina, We had a great presentation last week on housing and the impact of when you think about health. If you're a hospital administrator, do you really spend planning time talking about housing? Probably not. Do you think you should? Probably not. But when we think about people that end up in our emergency room because they have nowhere else to go, housing is a part of the problem. And so we have got to, again, look beyond our typical what we went to school to learn how to do and recognize that this collective thinking and brainstorming, collective learning around the impact of any component of the healthcare delivery system that's broken, it's going to affect all of us. And so I think the South Carolina Health Coordinating Council, the Institute of Medicine, DHEC leading the obesity charge, all those are significant for South Carolina because it's really the first time that we're bringing everybody together from crazy places, whether it's the jail or law enforcement or the school counselor or the hospital administrator or the doctor or the social worker. It's bringing everybody together to say, here's the problem, let's understand it, and then we can go back and say, what's my role in contributing to solving the problem? And you're going to have collective thinking on behavioral health. It is too significant and too rampant, and it affects all of us.
It really does, whether people want to acknowledge it or not. Eleanor, that's a great segue to get back to you about what you think will be the feasible next steps for the provider community to really partner more effectively with the grassroots improvement for the health of our population.
Sure. I mentioned local coalitions in communities, and one key role would be to connect with those local coalitions, bring the expertise, bring the human capital, bring the planning expertise, the messaging, the marketing expertise to the community, and partner with neighborhood residents. We talk about the folks who are not at the table, but literally going out in communities to talk about the environment and to observe the environment where residents who are discharged live in their homes, and really partner with municipalities, partner with county governments, partner with EMS, partner with others to change the environment, to build a community through policy and environmental change that support health and well-being. But I love Roz's statement about looking internally first, because it's one thing to go out and begin partnering, but if you don't have your own sort of shop in order, and knowing the role of the providers, whether it be hospitals or individual providers, to begin practices within their own clinic settings, like doing BMI screenings at every visit, counseling on knowledge of BMI, counseling on the importance that I was talking with my table about. Literally, we write prescriptions for medications, and we talk about the negative impacts if we don't take those medications, if how to get those medications, but really the same time spent on health, and really connecting our patients to those supports, the social support and the physical supports for health and well-being. To me, those are the next steps in truly building those collaborations at the local level. And it's already happening, as Graham mentioned, at the state level. There's collaborations that are forming that really are looking at state policy, state systems. But every community is unique. Rural, urban, even within inner cities, neighborhoods are very unique. So when we're looking at health disparities and higher rates of obesity in low-income neighborhoods, we have got to work within those communities to develop the strategy. So getting outside of the hospital walls, getting outside of the health center walls, and into the communities is really where I see the next steps lie.
And Dr. Picklesheimer, I want to come back to you because I think our theme here has been on collaboration. And I think, most of us might agree that mandates certainly have a good intention of trying to get to a better outcome, but I think we have a much greater rate of success and higher success when we can instill that passion, whether it's our own health care and getting involved or eating better, moving more, or into some of these initiatives that we've talked about. What was your passion that got you inspired to really be passionate and involved in the Birth Outcomes Initiative?
I think you know, most doctors are very busy, have full schedules. We all have been behind, in a doctor's office where they were running behind and we had to wait. And I think the focus is, it's easy to look at those patients in your waiting room that you're responsible for, those charts in your back office. But to me, really, the most exciting thing is to think about what I can do to take care of the women in my state, and not just in my office. And one of the privileges I've had being engaged with birth outcomes is to see how many other people there are that are equally as committed to making the state a better place. I mean, there is just so much positive energy. It's so exciting to hear all of these amazing ideas. And I think we're doing a better and better job collaborating and bringing people together from different areas. And the energy that we have in the birth outcomes meetings is just incredible. I think, you know, sometimes the work gets done through email and over long distance, but when you can actually bring people together in a room like you all are meeting today, it's amazing how much you can catalyze action. And this is such a fun time to be in medicine, and it's also a really exciting time, I think, to be in South Carolina. So.
Well, thank you for your work. We appreciate that. Lisa, I want to come back to you. They've talked a little bit about businesses being involved, and I want to hear from you. And you talked on this earlier, and Roz also mentioned that more businesses are reaching out to the South Carolina Hospital Association with the Working Well project. But just kind of drive home for us why the business community should care, why it needs to care about the quality of care, the cost of care, and the health of our community.
Well, the business community really is paying the majority of the healthcare costs in this country. So it's an economic imperative for them to get a handle on things. And it's really interesting. I was thinking, you know, during my career, it used to be about cost, and the way they looked at it in the 80s and 90s was drive that fee schedule down, drive that fee schedule down. Well, did that work? No, clearly not, or we wouldn't be here today. So I think it's come around so that employers are really thinking we want to reward providers who give high value, high quality care. And how can we do that? So it is very, very important to look at cost in a different way, I think, while at the same time being mindful that some of our employers are global in scope, and they take a lot of heat from owners in France and Germany who are saying, why are the healthcare costs so high in South Carolina? And the outcomes, you know, don't really follow what you'd think that cost should provide. So they do have a terrific imperative. And I wanted to comment on something Eleanor said earlier. We need to not only focus on the employees that we currently have in the state, but attracting new business to the state. And economic competitiveness, we have great advantages in this state, but healthcare costs at this point really aren't one of those. And we need to turn that around in order to attract more business as well.
That's an excellent point. Excellent point. Now, audience, if you all have any questions, we'll be wrapping up in the next few minutes or so. So I have a couple more questions myself for our panelists, but don't hesitate to raise your hand. I know they've covered a lot of great ground and have done a phenomenal job, but if you have questions, we want to make sure that we address those as well. Rosalind, I want to come back to you because we've talked about, you know, the initiative and starting with their own house, you know, with the hospitals, but now reaching out to the businesses. As you've done more of that connecting with business partners in the community, has your observation been that they have many of the same challenges that you see in the hospitals, or are they very unique and different from what you're facing in the hospitals?
Probably both. An advantage hospitals have is that we have clinical expertise on staff. When we go out to some manufacturers and some other organizations like municipalities, they don't necessarily have that advantage. So we can put on a class or a program, an educational program, and just delegate it to someone on our staff. Some of those organizations may not have that. In those cases, our hospitals are partnering with those organizations to offer those services and come into that employer to provide those same services. Some of them also have some different challenges too. I mean, if you try to get rid of sugar-sweetened beverages in a manufacturing plant, it may not go over as well as it would in a hospital. Although hospitals give some grief too. And we've really only had 2 hospitals to do that so far. So there are certainly some challenges, different challenges for unique settings. It really varies site by site where they're located. Some of the environmental changes that hospitals have been able to do as far as smoke-free campuses and walking trails. Some of the organizations we're working with are municipalities or other work sites don't own the building they're in. So they've had to negotiate with the owners of the building to make a lot of different changes in those. So, but we've coached them through those changes. They're challenges, but they're challenges that can certainly be overcome.
Thank you very much. Renee, I wanted to come back to you. You mentioned earlier that your hospital's been able to drop the cost of charity care. I think you said $35 million? Yes. That's a huge number. What do you see the impact on charity care being with the implementation of the new health care law? I mean, do you see that cost dropping even further, being able to shift those resources in other areas, or is it too early to tell? What should we expect?
Ooh, that was a nasty question. So I'm going to kind of answer it, I think, the way you asked it. But I think one of the interesting things going on, there's some unfortunate things and some positive things in South Carolina. Unfortunate is that we chose not to expand Medicaid, and that's not a comment, a political comment. It is what it is, because the way the Affordable Care Act was designed, you were supposed to expand Medicaid, which would cover people up to a certain level, and then you would get in the health exchange above that. So now in South Carolina, we still have a number of people who are not insured and not eligible. So that's unfortunate. But the great thing that has happened is through the legislature last year, they passed a proviso that encouraged all hospitals, and every hospital did agree to participate in the Healthy Outcomes program. And I think it is one of the greatest opportunities we've got in this state to continue to help folks who are living in low income, uninsured neighborhoods, help them really get back on their feet and figure out their health issues and address the barriers that get in the way of them caring for themselves, because that program is incenting us to work in partnership with our community partners to figure out what's driving those costs, and then to help build in infrastructure in the community to address the issues that are driving those costs. So for us, the number one cause for low-income uninsured people in our community who are overutilizing the ER, in volume, it was behavioral health. In cost, it was behavioral health. So in our community, we are working in partnership with our competitor hospital, which I'm excited about, to build in extra infrastructure in primary care and in behavioral health. Because we know we can't just send you to a doctor and assume you're going to get well. If you're mentally ill or you've got substance abuse issues, we've got to treat those things together. So we're trying to blend those two issues together in an environment to care for people, and then support them with psychosocial support and other social resources, whether it's housing or other issues like that, to try to take care of the whole person. And what we found is that when you help people get back on their feet, they end up being able to walk and run on their own. And so we love the potential for success there, and I think you're going to see that across South Carolina as more hospitals start to adopt this philosophy of we've got to invest to save. We've got to invest to improve health. And when we invest to improve health, we are going to save.
Thank you. Dr. Adams, as we start to wrap up, if you could briefly describe for us the role of individual organizations in helping to achieve the statewide triple aim improvement goals that are going to be launched in the summer.
You know, I think and those goals really are improving the patient experience, improving the quality of health outcomes, and then cost. And more that is becoming kind of the commonly accepted benchmark for where folks need to go. And as we look forward towards that, and as individual healthcare facilities start to think about costs, start to think about some of the things that Lisa talked about, and the patient experience. For years, hospitals have done kind of patient satisfaction surveys, but all that has been kind of, those three things have been thought about separately. The patient experience, reducing cost, and improving quality have been kind of different departments and different mindsets, and I think linking them together is really where you get synergy, and it's really where you get the impact to improve the patient outcome and improve the system as a whole. And I think we've seen some success around that already. The Hospital Association has offered a lot of leadership there, and this conference alone, I think, has really helped to underscore how many people are interested in this, and again, are kind of viewing that as kind of the commonly accepted goal. one of the frustrating things for a lot of us that work in healthcare is there's so many different efforts around one thing, be it quality. The feds alone can have several different quality efforts that they make hospitals and then community health centers and rural health clinics and different providers, EMS, they all have their different quality measures, and people are all quote unquote trying to improve quality, but they're not working together because they all have their own metrics. The Triple Aim, I think, is that common platform that folks can work towards and really look at those things from a coordinated fashion.
Thank you very much. Again, just a couple of minutes left. David, last question to you, and it's really pretty simple. As you look at the pilot program and trying to move forward, you already have a number of partnerships, but is there any particular new partnership that you think could really be critical in making this effort work?
I think the most crucial relationship is probably going to be with the payers. So that's something that I think we're starting to look towards. You'd be amazed at the community resources that are out there that you don't know about. Graham talked about, all these different groups that are working on quality. There might be 3 or 4 organizations in a community that are working just simply on coat drives or canned food drives and things of that nature. We don't think about it. Just as I'm sitting up here listening to the discussion, the Federal Emergency Management Agency and the disaster preparedness world, they've been moving to a all hazards, whole community approach. So in the emergency management world, we used to spend a lot of time planning for just a train derailment, just a tornado, whatever the case may be. But in a tornado or a train derailment, you're going to have to evacuate folks, you're going to have to house them, you're going to have mass casualties, you're going to have all these things. So instead, we started focusing on the downstream effects of a disaster that we knew were going to happen, and now we spend our time planning for those. What we're talking about here, I think, is a whole community approach to healthcare. And I think that's something that's interesting. And if anybody wants to find out more about it, just Google whole community FEMA when you get back. There'll be tons of great slides and information that you can build into your presentations as a little time saver. So take away.
Well, thank you very much. And on a note of personal privilege, I want to thank all of the paramedics for the hard work that they do. They actually saved my husband's life. I got a call at work one night saying that my 3-year-old had fallen, hitting his head, and as soon as I walked in the door and they saw the blood everywhere, they told me that it wasn't my husband's fault. So everybody was just fine. They saw the look on his face. They said, oh, he was scared when you walked in the door, but thank God everybody was fine. Let's give a big round of applause to our panelists. They did a fantastic job. I want to make sure that we stick to the schedule, but we do have exactly 2 minutes left. If you all, does anybody have any burning, pressing questions from the audience? I know they did a really phenomenal job of covering a lot of ground in a limited amount of time. So going once, Dr. Foster? Yes.
Maybe you could spend just a minute talking about considering pregnancy from 2 perspectives. Changing the way we're providing health improvement and health care.
Mm-hmm. Okay, 30 seconds each, Amy.
The last speaker mentioned centering pregnancy, and just so that everyone can know that we're doing a statewide expansion of access to centering because it's been shown to have promise in reducing the racial disparities in birth outcomes. It's supported by DHHS and March a Dime. So there's funding available if anybody is interested in bringing a centering group to their community. Come find us through Birth Outcomes Initiative, but that's just an example of using resource we already have and changing it to move it forward into being a more efficient way. And we've partnered together with Medicaid to be able to, one, help doctors with the startup costs of transitioning the way they deliver care, and then also reimbursing them for a care model that's heavy on prevention, but is more expensive for them to deliver in their office. So we can show that we're saving dollars by preventing NICU admissions. So moving that in from the payer perspective, just like David was talking about, moving it from acute care in the NICU to the, which is, a different type of doctor, to the OB provider that needs to invest in this prevention model. So it's really exciting to see the transition from a volume-based healthcare system to a value-based healthcare system. So
fantastic. Amy Pickles.
And we're leading the state in that. We're the first state in the country to do a coordinated rollout and expansion project. So nationally, we've received a lot of attention for that. So
more good news for South Carolina. Yeah. So to Amy Pickelsheimer, to Eleanor Dunlap, Rosalind Goodwin, Graham Adams, David Porter, also Renee Romberger, and Lisa Ware-Ellington. Thank you, our panelists. Let's give them one more big round of applause. And thanks to all of you for all that you do to make South Carolina a better, healthier, place to work and live and raise our families. Thank you, ladies and gentlemen. Thank you. Thank you. Thank you.